Hey, I'm sitting here trying to remember how to pronounce the word that I need to say. But hey, today we're going to talk about surgery, some cosmetic surgery. Or is it cosmetic surgery? Is it a necessity? That's what I wanted to find out today with my guest, Dr. Emilio Justo. And I'm talking about eye surgery, not like glaucoma kind of thing, kind of like an eye lift, but it's not exactly or not really an eye lift. It's called blepharoplasty. Blepharoplasty. Let's say it together. Blepharoplasty. There we go. That's what it is. So Dr. Emilio Justo is going to talk to us about that. We're going to find out, is it more of a cosmetic surgery, or is this something of a necessity for some of us? So in fact, I asked, for me, would I be a candidate or not? Is it covered by insurance? How much is it going to cost out of pocket if I don't have insurance? And is it an inpatient or outpatient type of surgery? So hopefully you listen to this, because he is a leading doctor in this field, and you're going to find out maybe you're a candidate for this. Maybe you want to get something like this, and maybe it just might be a necessity. And before we get into it, please remember, if you're a pet owner, please be a responsible pet owner and have your pets spayed or neutered. And let me say this. If you have not subscribed, please consider subscribing, following, and commenting. Thank you. That surgery is more popular than I realized. And if you don't mind, I'd like to talk about, what are the procedures that involve, doing this, and what's the purpose of this? Is it vanity, or is it something else?
Sure. No, I'll be happy to talk to you about all of that. I'm
Okay.
I'm all in. That's one of my favorite things to perform.
Oh, is it? All right. Well, what are these procedures, and why do people get this? Is it something other than vanity? Because doesn't it help with your appearance and your eyes and the dark circles and things like that?
Yeah. So certainly blepharoplasty, of course, has the benefits of aesthetic enhancement. Person looks younger, feels younger, increases self-esteem, self-awareness, of course. But the reality of it is that it brings along an incredible amount of functional improvement, particularly in cases where it's more significant, right? A person who has heavier eyelids, droopier eyelids, they're going to have more functional improvement. Who's somebody who just has a little bit of redundancy of skin and they're strictly doing it from a cosmetic standpoint. In my practice, we do a lot of the upper lids as functional or as medically necessary. And that's kind of one of our claims to fame, one of our niches that we've become so popular for is because we are very good at getting insurance authorization, etc. Now, of course, when we talk about lower eyelids, which is a whole nother animal, people who have big fat pockets, or they call them bags under their eyelids, those are purely 100% cosmetic, aesthetic, non-insurance, 100% of the time. Upper eyelids can improve heaviness to the eyes, fatigue to the eyes, can help open up peripheral vision so that people have better peripheral vision side to side, etc. So there's a whole host of improved physical aspects and functional aspects where upper eyelid blepharoplasty can be of significance.
Okay. How is it determined that one either needs or is a candidate for this surgery?
Well, if one is looking at it from a functional or medical standpoint, then the first thing, of course, is that the patient, let's say, comes into our practice and is complaining, has subjective complaints of either heaviness, fatigue. Sometimes they can even have some headaches associated with the fatigue or eye strain. They may or may not comment on their peripheral vision. Some patients do, others don't. So it's basically first the subjective complaint. Once they have the subjective complaint, then I, of course, am going to evaluate their eyelids, and we're going to document how much redundancy of the excess skin and fatty tissue, how much it's covering or getting close to covering their pupil, the little round black hole in the middle. And then if one is going to submit it to insurance for authorization, insurance companies need three main things. Number one, of course, they need the actual consultation report with all the documentation of the subjective complaints and the physical findings. Number two, the insurances need photos. So we take photos, both what we call frontal, straight ahead, and then side photos from each side. And then thirdly, they need what are called visual field tests, which are computerized tests that measure the peripheral vision. And there's a software program that's specific to eyelid surgery, which measures just the superior visual field, because the machine itself is the same machine that's used to do a whole array of visual field tests for different diagnoses. Like, for example, a person who has glaucoma or borderline glaucoma is going to have a visual field test. That's just part of the protocol. But that software is testing all the way around 360 degrees. In this case, with heavy eyelids, we're not concerned about the lower visual field. We're just concerned about how much is being restricted in the upper visual field and how close it's coming down to fixation. Fixation meaning straight ahead. Okay. So those three components, the documentation, the consultation notes, the photos, and the visual field testing themselves have to then be submitted to the insurance for authorization.
So we'll take me as an example then. If I come in and I say, Dr. Emilio, I'm having this problem. It seems like I get tired. My eyes feel heavy. And right now, I look at my eyes and I say, it's not covering my pupil. It's not coming that far down. But I do know that I forcefully have to open my eyes wider if I want to be able to see things clearer, or it seems like it helps. Is that a potential candidate?
Absolutely. That is actually one of the most common things that people say, is that they have to force their eyes, and when they force their eyes to open wider, they see better. That we hear all the time. And keep in mind, it's not that the heaviness of the eyelids is necessarily covering the pupil. That's actually an extreme example. It's just that it's coming down closer to the pupil. So we actually, there's a term called MRD, which stands for marginal reflex distance, which is the approximate number of millimeters from the pupil to the eyelid. That spacing between the pupil in the middle and the eyelid. And so that's part of the documentation as we write down the MRD, also known as RMD, reflex marginal distance. They mean the same thing. But basically, so as the lids get closer to the pupil, that's the important part. It's only in a minority of cases where the lid is actually covering or below the pupil. That's a really extreme case. But also I should mention, not to confuse you or to confuse the audience, but there are two different distinct types of ptosis or blepharoptosis. Remember, ptosis is the terminology that means droop. But ptosis can refer to any type of droop, right? So if you're looking at a plastic surgeon who's doing a breast lift, they talk about ptosis of the breast. In this case, we're talking about the eyelids, and so it's referred to as blepharoptosis. Bleph is, I believe, the Greek word for eyelid. So blepharoptosis is drooping of the eyelid. But there are two distinct categories. The most common is when people have kind of heaviness from the standpoint of flaccid skin and fatty tissue, right? And what I call the so-called hound dog look, where you just have a lot of flaccid skin coming down with or without fatty tissue. That's the most common, and for that we do what is known as blepharoplasty. Blepharoplasty is what the public, the lay public, refers to commonly as an eyelid lift. However, that term, eyelid lift, as it relates to blepharoplasty, is really a misnomer because we're not physically pulling the lid up. What we're doing is we're removing the redundancy of excess skin and fatty tissue. The lid position, meaning where your eyelashes are, where the eyelashes come out of the lid position does not go up. So the eyelid lift is a bad term, but blepharoplasty is by far, I think if I'm not mistaken, according to the American Society of Plastic Surgery, that's the number one most common aesthetic procedure. And of course, we're talking in functional terms, but it's the number one most common plastic surgery done in the country today. However, a second common type of blepharoptosis, which I see a lot of in my practice, particularly because I see also not just young people, we see a lot of young and middle-aged people, but we also see a lot of senior citizens. And that is ptosis that is related to what I call muscle weakness. And that is where the muscle that lifts the eyelid, just typically through natural aging, becomes weaker, and the lid position itself, regardless of whether there's excess skin or not, that's irrelevant. But the lid position itself gets closer and closer to the pupil, and in extreme cases, it can cover the pupil. So that's a muscle weakness, and that requires a different type of procedure, what generically I refer to as a muscle tightening procedure, to physically elevate the lid. So that really, truly is a true eyelid lift. But that's not what people refer to. When the general public says, oh yeah, I'm going to go in and have an eyelid lift, I can assure you that 99% of the time, they're referring to blepharoplasty, just removing skin and fat. But in the older population in particular, many of them need muscle tightening to actually make their eyes open up and lift that lid. So instead of having that bedroom eyes or that sleepy-eyed look, their eyes become bigger or rounder in appearance. Why? Because the eyelid is being lifted up. And so the eye then looks rounder. Not that you're changing the actual size of the eye, but it just you see more of it. So it's a little confusing, but I just wanted to clarify that.
Well, I do have two questions in on that front. One of it is you see these, I'll just say, celebrities, Hollywood stars who get the eye lift, and you see that it looks
like a deer in the headlights.
So right. So your type of procedure that you're talking about is not that, and it won't be or should not be one of the side effects of it, right?
That is correct. And again, that's a super common comment that I hear with almost every patient, that they say, oh my gosh, I don't want to have that deer in the headlights look. And really, when we look at those celebrities that look that way, honestly, one never knows what exactly they had done, right? Because that's not, discussed or made public. But a true blepharoplasty, if that's the only thing that they're having done, a true blepharoplasty should never do that, because you're just removing skin and fat. I mean, unless if you overcorrect, right? If you take too much skin and fat, then you can't close the eye properly when you're sleeping. But it should never give a deer in the headlights look. So really, when we see that, I wonder to myself, okay, that person really had some other procedures done. They might have had blepharoplasty, but in conjunction with that, they had other procedures done. Did they have muscle tightening? I don't know. Did they have some type of brow lift or forehead lift? I don't know. I don't know what they had done. But clearly, we've all seen those celebrities, you and me and everyone, where you look at them and you think, oh my goodness, what did they have done? They look so much more natural before, and now they simply look unnatural. One great example, and I say this out of sheer love and respect, because he's one of my dear, my favorite artists, singing artists over the years. And unfortunately, he's deceased now. But you may recall Kenny Rogers, right? And Kenny
Yes.
Rogers, I always thought was such a handsome, handsome man. Way back before he had any type of cosmetic surgery done. And then I remember, I don't know, 10 years ago, 12 years ago, walking in and I saw someone on TV I asked my wife, hey, who is that? And she said, oh, that's Kenny Rogers. And I was in shock because I literally did not recognize him. The change was so over the top, so dramatic that I thought to myself, oh my goodness, I thought he was more handsome before. And there's plenty of examples of females in the same situation where, I think they looked more natural, right? To me, it's all about creating improvement, whether it be aesthetically, functionally, or both, but creating it in a natural way, not to make someone look like there's someone else. And that's another common question that I get is patients will look at me as I'm explaining the procedure. They say, hey look, I don't want to look like anyone else. I don't want people to look at me and not recognize me for who I am. And I chuckle and I say, trust me, you will look the same. People will recognize you. You will just look more refreshed, more alert, more rejuvenated. But you're not going to look like someone else, and you're certainly not going to look like a deer in the headlights.
My other question about this is, does lack of sleep play a role in your eyelids getting that heaviness or causing you to, or causing that the eyelid to not be as strong and lifted?
I think truly from a direct standpoint, I don't see a direct correlation there. Now, there's no doubt in all of us, right? If we aren't getting good sleep or we've pulled an all-nighter or whatever the case may be, that fatigue and that lack of sleep is going to manifest in our facial features, not just our eyelids and even in our how we conduct ourselves. So there may be some indirect role on a temporary basis. But no, as far as permanency or long-term implications, no, I don't think that, let's say someone who works 2 jobs and only sleeps 4 or 5 hours a night consistently for 10 years versus somebody who gets 8 hours a night consistently for 10 years, I don't think that makes one's eyelids age or droop any faster due to lack of sleep. Okay. So I think that's just, in my opinion, a myth.
Okay. Fair enough. I'll continue staying up all night.
There you go. There you go.
You mentioned like the breast lift, the augmentation, and things like that. And I hear sometimes that they have to go back in and relift and things like that. So with this blepharoplasty, does this surgery mean that I have to go back in 5 years to have it done again, or will it last a lifetime, so to speak?
Wow, excellent question, Chuck. You're really thinking very clearly. I commend you for that, because seriously, these are great questions. Another question that comes up in the consultation room, and so the way I answer that is a couple ways. Number one, certainly the procedure is not necessarily a permanent procedure. A lot of it depends upon at what age you're having it done to begin with. Because I have patients who are very young. This is a minority of our patient population, but just a couple weeks ago, I had someone in their early 30s who I did blepharoplasty, and they already had, fairly kind of heavy, fatty eyelids, but it was purely genetic, right? Because genetics plays a role. If you're mother, grandmother, or father, grandfather, siblings, if they have heavy lids, it's not uncommon that you may have heavy lids. So if we start at a young age, and let's say they're even 40, it's not uncommon that they may have the procedure again, and that could be anywhere from, on the early side, it might be 6 or 7 years. More commonly, I would say it's more 10 or 12 years, and sometimes it's 20 years later. So it varies tremendously. But what I do find, because this is an important point, is that when they come back to have it done again, it's never as bad, or I shouldn't say never, right? Nothing in this life is ever black and white, but it's rarely because it's as bad the second time as it was the first time. What I find is that once a patient has it the first time and they've become so used to and almost addicted to their improved aesthetic appearance and their improved functionality, that they are then more apt to have it done a second time and not wait as long, because they already know what can be done. I mean, they've already been through it. They know that there's something that can be done. So when I see them, because I would say roughly 15% of all the blepharoplasties, I mean, I do a lot of blepharoplasties. I do close to 800 a year. And I would say roughly 15% are what we refer to as secondary blepharoplasties. That is, people who've had it done at least once before. Every once in a while, I'll see somebody that we're on their third blepharoplasty, right? They had it, for example, when they were 40. They had it again when they were 55. Now they're 70, and they're on their third one. So that can occur as well. The second, third time around, it's rarely as bad as it was the first time. But the first time around, a lot of these patients will tell me, they say, gosh, I would have been in a lot sooner, but I didn't know anything could be done until I came across my friend and I saw them and I said, okay, you look different. You look more refreshed. And they told me that they had this surgery, and that's what got me thinking about it, right? A lot of these people just simply did not have an understanding that something could be done to help. So now that they've had it and they know that something can be done, they're more likely to do it again in the future.
Well, yeah, you've clarified, demystified some of my thoughts about this, is where I did not want to look like that deer in the headlight or that celebrity facelift gone bad type of thing. So I'm going to be that guy that's in Dr. Emilio's office, sitting in that chair for my consultation, and I'm going to ask you and say, is this a procedure where I have to stay the night, or is this something that is called, or is it an in-office visit? I go in there and it's a few hours and then I'm able to go home.
Right. So it is an outpatient procedure. Now, I can only talk about our practice, which probably is the majority of the country, but a couple things. So if we're only doing upper eyelids can easily be done even under local anesthesia, meaning that the patient does not have to be either medicated orally, or they don't even have to have an IV necessarily. Now, we do have many patients who actually want to have a little bit of IV sedation because, understandably, they're a little nervous, they're a little anxious. So that's okay. And then others, we will just give them a little oral Valium, which is just a mild sedative. They're still awake during the procedure. So we'll do it that way. And then there's the third category, which is probably the minority of our patients, but we do have those that don't want any type of sedation whatsoever. So we just, of course, numb them, as we do all patients, with a little bit of lidocaine to numb the eyelids, but they're completely 100% wide awake. Now, in all cases, they do require a driver home. You can't drive yourself home. Mm-hmm. So upper eyelids can be done every which way, local with oral sedation, local with intravenous sedation. In our practice, when I do lower eyelids, the vast majority of my lower eyelid blepharoplasties, I use a hidden incision inside the lower eyelid, not on the skin. The upper lids, the incision is always on the outside, going across the eyelid crease, because we're removing skin. Right? The lower eyelids, primarily I'm removing fat. I only remove skin in very, very select cases. And sometimes once I remove the fat, I'll do a little what's called laser resurfacing, or a little laser peel to give some texturization to the skin. But in our case, because we're very, very unique in that in our medical office building, we have our own licensed, accredited and Medicare certified outpatient surgery center. It's a true outpatient surgery center. So we're doing it as an outpatient surgery procedure, just like if you were going to the hospital and going to their outpatient surgery facility. So as such, we have our outpatient surgery center so we can do general anesthesia. So on the lower lids, our anesthesiologist will give them a little IV sedation, but it's a deep sedation, similar to those of you or in your audience who may have had a colonoscopy before. You know, in a colonoscopy, which is a short procedure, but most of the time you're basically put to sleep. The sedation, it's IV sedation, but you're not awake typically. And so that is considered general anesthesia. A lot of people don't realize that. They're going to say, oh, I'm going in for colonoscopy. But it's considered, if you ask any anesthesiologist, that is general anesthesia when you can't converse. If you can't talk to your doctor or whomever, then that's general anesthesia. So when I do lower eyelids, 100% of the time, because the lower eyelids are much more stimulating, they require a lot more pressure, pushing, pulling, etc., then the patient is out. If we're doing the uppers and lowers combined, which is quite common, then they're out for the whole procedure. So it just depends on what we're doing. But in all cases, it is an outpatient procedure. It's not a long procedure. You know, upper eyelids typically take me 20 to 25 minutes to do both upper eyelids, lower eyelids, maybe an extra 5 minutes or so. So we can do the upper and lower eyelids easily in less than an hour, and then the patient will go home.
I'm still sitting in that consultation chair, and I just have a few more questions to ask my doctor.
Sure.
One of which would be, will I notice the immediate effects of this, the benefits of it, and also is there minimal scarring, and are my eyes going to be all bruised looking for several days, so people are going to look at me and say, what fight did you get into?
Right. So there is definitely bruising and swelling associated with it. Now, how much and how little is really impossible to predict. And I've just learned this through doing this for 36 years. Every time I try to predict, I'm always wrong. Now, there are certain precautions that we take in an effort to try to minimize bruising and swelling, and that is reducing any type of blood thinning medications over the counter and prescription. So as an example, we try to make sure our patients stop any low dose aspirin a couple weeks prior to the procedure because it's a blood thinner. We try and avoid any what are called non-steroidal anti-inflammatories. That includes your Motrin, ibuprofen, Advil, Aleve, etc. We like to stop that 1 week before. What they can use is any type of Tylenol or acetaminophen product because that has no effect on blood thinning. Also supplements, right? So a lot of people take supplements. So certain supplements like your omega-3 fatty acids, your fish oil, krill oil type supplements, or any excess vitamin E like Edward, we like to stop those. You know, multivitamin, that's okay. Now, the more challenging part becomes if the patient is on a prescription blood thinner, right? Some people, for example, have cardiac conditions and they may have AFib, atrial fibrillation. They're on a prescription blood thinner. They may have other conditions that require prescription blood thinner. Then we have to get a medical clearance and make sure that their doctor, cardiologist, whomever, allows them to stop it for anywhere from 3 to 5 days prior to the procedure. And so those things we do automatically. But even take the case of someone who's never been on any blood thinners, over-the-counter, prescription, nothing. They're healthy as can be. Yeah, we explain to them that they're going to have bruising and swelling. Now, is it possible that they could have a minimal amount? Sure. But can I tell them that? Absolutely not, because they could end up, possibly looking like Mike Tyson after 12 rounds. We just don't know. Everyone is different. So they will have instructions on, icing or doing cold compresses the first 2 or 3 days to help with that. Your other question is, can they tell something immediately. And generally speaking, in the majority of cases, they can. Why? Because the bruising and the swelling typically set in about 24 hours later. I mean, they may have some degree of bruising immediately, but the swelling usually isn't bad until 12, 24, 36 hours later, and the body then mounts that reaction, and the eyelids may swell. So typically they do see an improvement right away when they're in the recovery room and we show them in the mirror what they look like. Generally, they're very pleased.
Minimal scarring because it's in the crease of the eyelid?
Correct. That incision, eyelid skin is the thinnest skin in the body. And so I have found another common question that some patients ask is, I've had other surgeries, and they'll show me on their arm, on their chest, on their back, and I keloid or have a hypertrophic scar. And I explain to them, yes, that's because in those parts of the body, number one, your skin is very thick. Number two, the skin is very taut. It's very tight, right? If you're cutting into someone's forearm or into their back, the skin is a completely different texture and level of tautness. In the eyelid skin is almost paper thin. It's so thin, and the last thing we want to do with any surgery is make the eyelid that tight, right? Because number one, it won't look good. Number two, they may not be able to close their eyes, etc. But going back to your question, as far as scarring, rarely is that an issue. I mean, in my 36 years, I can probably count on one hand, maximum two hands, where I've had to go back and excise an existing incision or scar to replace it with a fresh new incision. That's extraordinarily rare because typically it does heal very, very nicely. That's the beautiful thing. And it's placed in that crease, so it really follows the natural crease line. So it's rarely an issue.
Okay. Well, I'd like to do this, but I have one last question for you on this, which is an important one for me if my insurance cannot cover it, is how much is this going to cost me out of pocket? Or is there an estimate?
Right, great question. And that, I can give you more specifics here in a moment, but I will say that that's going to vary tremendously on a variety of factors. The most obvious factor is the geographic place that you're in, right? Certain places, if you're going to Beverly Hills, it's probably going to cost you 3 times as much as if you're in the middle of Arkansas, right? So some of it is geography. Some of it may be just strictly based upon the surgeon. I will readily admit, I won't be shy about admitting this, that in my early years, because as one is building a practice, you tend to charge a little bit less to just get the volume. Now, I'm booking my surgeries into February right now. That's how far out we're scheduled. And same with consultations, that I'm not, in dying for business. And so the busier one gets, what happens is that your fees do tend to go up a little bit, right? Because, it's just the way, supply and demand. So, but then there are other variables, right? So there's other variables insofar as, are we, if we're doing it in a true facility, which most surgeons do, most surgeons are going to go to an outpatient surgery center. Again, in our case, we have an outpatient surgery center. It just so happens to be located inside of our medical office building. So for the untrained eye, they may think that they're having it done in my office, but we're very clear in explaining to them that we have our own accredited, licensed, certified outpatient surgery center in our building that's licensed by the Arizona Department of Health Services. So it's a separate entity from the practice. Theoretically, one could have it done in an office-based setting, right? So there are certain doctors who may do it in their office, and they may have just a designated exam room that's for small surgeries. In which case they may do the procedure there. But those procedures would be done under local anesthesia with or without a little oral sedation. You're not going to have, typically in an office setting, you're not going to have an anesthesiologist present. That has to be in a true surgery center. So, going back to your question, in terms of cost, it's going to depend upon, are you just paying the surgeon's fee, which is called the professional fee? Typically, when you go to any type of surgery center, whether it's a freestanding outpatient surgery center, if you go to your local hospital that has an outpatient surgery center, there is what is known as a facility fee. And the facility fee is for the operating room, the nurses, the supplies, et cetera, right? So when you go in to have your colonoscopy, I can assure you that the GI doctor is billing the professional fee, the center, the colonoscopy center, is billing a facility fee, and then what's the third component? The anesthesia provider.
Anesthesiologist.
Right, so they're paying their fee. Now, in our office, this part, it's super unique to us because it's all under one roof, even though we have those three components. When we quote someone a fee, because we want as least amount of confusion for the patient as possible, we charge them what we call a global fee. If it's cosmetic. If it's medical, it's different because it has to be billed to the insurance. But if it's a cosmetic self-pay, we have one global fee, and it includes all three of those components bundled together: the professional fee, the facility fee, and the anesthesia fee. That's extraordinarily rare. Now, if it's a medical procedure, then all three of those components will be billed to the insurance company, whether it's Medicare, Blue Cross, Aetna, whatever the case may be. And that's standard. It's the same for your colonoscopy. The insurance company is getting billed by the doctor, by the operating room, and by the anesthesia. So when you ask, how much will the person, if they're paying out of pocket, how much could it possibly run? I would say that on average, the low and the high end of an upper bilateral, meaning both eyes, upper eyelid blepharoplasty is going to range anywhere from, on the low end, $3,000, on the high end, $5,000. Now, I know that sounds like a big spread, but again, it just depends on so many of the other variables we talked about. In our practice, we're pretty much right in the middle of that, so we try not to be extreme on either end. But that would be kind of the low and high end. When it comes to lower lids, it's going to be a little bit more because in the lower lids, number one, they're always cosmetic, as I mentioned earlier. It's never an insurance. And number two, it definitely, at least in my way of doing things, it's always going to be in our facility with our anesthesiologist giving medicine where you're going to be in a nice sleep so as not to experience any discomfort. So there are those additional costs. So definitely the lower lid blepharoplasty is going to be a little bit more than the upper lid blepharoplasty.
Okay. Well, I certainly have gained a lot of knowledge on this today, and I feel more comfortable about possibly doing this.
Great. Come on down. For you, Chuck, I won't make you wait. I'll get you in right away.
Well, I'm going to take a look in the mirror one last time and just open my eyes really wide, see how much it helps. But this really is eye-opening, pun intended on that, because I have heard local newscasters here in the Seattle area, or a local newscaster who had the issue with the eyelid and then had that type of surgery done. And again, when I was saying earlier that, no, I do honestly find myself, if I'm looking at something to read, if I force my eyes open, it seems like everything gets brighter and I can see better. And I've always wondered, well, what is that's going on? But I understand now. And it is good to know that if it is not a cosmetic procedure, that it is possible to have it covered by insurance.
Right. But I should say one other thing before I forget. If you're really looking to see if it can be covered by insurance, you really need to see an ophthalmologist who does this type of surgery, which is what I am. I'm an ophthalmologist, and I do a lot of what's called oculoplastic surgery. I can absolutely guarantee you that if you go to a plastic surgeon or some other specialist, because there's other specialties that do blepharoplasty, right? It's very commonly done by many specialties, ENT, oral maxillofacial, plastic surgeons, etc., that none of them are going to be doing it through insurance. So, so they're going to get some pushback. And that's, again, part of the reason over my 36 years that we've developed kind of a niche and are well known. I mean, I'm blessed in that I'm located in Sun City West, which is the northwest suburb of Phoenix. But I have patients every week when I do consultations that come from every corner of the state. And I have a number of patients that actually fly in from out of state. But again, we've established our reputation not only for the aesthetic improvement that they get, but the fact that we are exceptionally, let's say, talented at getting authorization. Not 100% of the time, no one can do it 100% of the time, but we know the system, we know how it works, and we're good and we're willing to do that to make it a win-win. Because when the patient has some of that cost paid for through the insurance, I mean, they're still going to be responsible for any applicable co-insurance, deductible, copay. Of course, that's with anything. But when we can help them win by defraying some of those costs, the patient's happy, we're happy, everyone wins. It's just a nice team effort. But again, only an ophthalmologist who actually does blepharoplasty, most ophthalmologists actually just, for whatever reason, don't do it, which I think is a mistake. So I'm on a mission at this stage of my life. I'm out there. I mean, I actually have in our office what I call a course, a 3-day intensive, to learn how to do the procedure, where I teach physicians, not just ophthalmologists, but of all specialties, how to perform both the consultations. They spend 1 full day seeing 30 consultations with me, and then 2 full days in the operating room where I do a minimum of 10 cases a day. And so they're looking right over my shoulders. I'm explaining everything I'm doing. I provide, 150-page syllabus to them that goes over every nook and cranny of everything we're talking about. So they leave that 3 days really well informed on how to perform the procedure.
Wow. Once again, folks, it's called blepharoplasty.
Very good.
It's blepharoplasty.
Right.
So, Dr. Emilio Justo, I want to say thank you because, again, this really has been very interesting. It's I can see myself needing this down the road sooner than later.
Absolutely, Chuck. Absolutely. And if you have any further questions, I'm here for you.
I do have one question. Do you have a website that people go to that'll tell a little bit more about the procedure and things on this?
Yeah, so I have 2 websites, just briefly. So I have the personal website, which isn't so much geared towards the patients. The personal website is, as you know, Chuck, as we've talked before, is more geared towards my blepharoplasty course for physicians, and also my public speaking and keynote speaking and TEDx speaking. And that website is dremiliojusto.com, DREMILIOJUSTO.com. But my professional practice website, where you have all sorts of information about blepharoplasty, other eyelid procedures, and many other procedures that I do. I do a ton of state-of-the-art laser-assisted cataract surgery. The practice website is AZ, like Arizona, I Institute, so AZEYE Institute.com, or you can spell it out. You can also spell out Arizona Institute.com. You'll land on the same page. And there, that website is exhaustive. I mean, it's just so in-depth with so much information on all sorts of ophthalmology topics and surgical procedures that they can find me there as well. And on either website, my personal or practice, if they go to the contact page and fill out their name and email address, they can send me a question, and it goes directly to me, doesn't go to someone else. I answer all email inquiries from either website myself personally. So feel free to reach me that way.
Great. Thank you very much, Dr. Emilio. I appreciate that.
Thank you, Chuck. I appreciate you as always.